Hello everyone, welcome to USMLE 4-week course by Team Magneto. Today we'll discuss about rheumatology. Rheumatology is about joints, connective tissue, and skin. In any exam, in USMLE Step 2 specifically, when the examiner is trying to put all these three things in a question, please go for rheumatological diagnosis. That's the key of rheumatology. Now, talking about the joints, the most important fluid is synovial fluid. Remember, in our body, any fluid is clear, any tissue is sterile. This is the mantra of rheumatology. When we talk about the synovial fluid analysis, I want you to understand that the septic joint, the examiner mentions the WBC count in the synovial fluid is 50,000 to 1,50,000. This is very important. You will have to pick this up in the question. D, could you please switch off your video? Thanks. So the synovial fluid analysis, the WBC count will be 50,000 to 1,50,000. Talking about the polymorphoneutrophils, that is nothing but the cells of the acute reaction. That is neutrophils, they are increased in the synovial fluid analysis. So septic joint arthritis, there will be raised WBC count and there will be raised neutrophils. Remember, if it is a tubercular infection or tuberculosis or chronic lymphocytosis, it is the lymphocyte count that is increased in the synovial fluid because lymphocyte is the cell for chronic inflammation. For acute inflammation, it is the neutrophil. You'll have to remember this. Talking about the inflammatory causes and inflammatory analysis of synovial fluid, we will see that the WBC are raised, but it is not that raised compared to septic joint. The WBC or the lymphocytes in the inflammatory, the WBC are less than 50% of neutrophils in the inflammatory. That is why the neutrophil count is not much elevated in synovial fluid analysis in inflammatory causes. Whenever I say inflammatory, what is it? It is rheumatoid arthritis, it is gout or pseudo gout. Now, talking about the most important thing, without which you will not find any question paper of USMLE Step 2. That is osteoarthritis, elderly patient, question stems, elderly patient, involvement of the knees, involvement of the distal interphalangeal joints, or involvement of the patient will be having wearing and tearing. The patient will be having increased activity. All these points towards osteoarthritis patient will be obese. In, in osteoarthritis, which is a non-inflammatory arthritis, the synovial fluid will be clear. The WBC count are not that much raised, so in the question you'll find at least 700 or 1200 WBCs of synovial fluid analysis. The polymorphoneutrophils will be still low compared to inflammatory arthritis. This is what I want you to remember. Everyone knows that the appearance of synovial fluid will be cloudy in infections, translucent or opaque in inflammatory, and clear in osteoarthritis. I don't want you to remember that. Classic thing on synovial fluid analysis, the synovial fluid appears cloudy with raised WBC of 75,000. What is the diagnosis? It is the septic joint arthritis. Next, we talk about associated antibodies and clinical scenarios. First, most important clinical scenario with associated antibodies is a female patient, young female patient with autoimmune conditions, presenting with thrombocytopenia, presenting with skin rash, presenting with rash on the face. That is SLE until otherwise proven. What is the confirmatory diagnosis or confirmatory antibody? That is anti-double stranded DNA or anti-Smith antibody. Very important. Remember, anti-dsDNA or anti-Smith DNA is basically 96% specific. I'll talk more about specificity and sensitivity when we are talking about biostats. But remember, 96% specificity for systemic lupus erythematosus is anti-dsDNA antibody or anti-Smith antibody. Whenever you find a patient taking petralizine, isoniazid, or phenytoin, you'll have to think that this patient has got a drug-induced lupus. The most important clues whenever you find these drugs in the question, it is drug-induced lupus. When we talk about drug-induced lupus, the specificity or the confirmatory antibody changes. It is the antihistone antibody that we use for drug induced lupus in order to confirm the diagnosis, because antihistone antibodies are 95% specific for drug induced lupus. And drug induced lupus, remember, in the question, you will find a male patient for tuberculosis treated with isoniazid, or male patient treated with hydralazine. Epileptic patient started with anti-epileptic medication in a female patient now presenting with rash, arthritis, that is drug-induced lupus. Very important. Next, we talk about the systemic sclerosis. The most important thing from my previous courses and previous lectures, I say that this patient has got systemic sclerosis whenever the systems are involved. Whenever the hands are associated with Raynaud's phenomenon in the question, please do think of systemic sclerosis as the most important cause. There are two types of systemic sclerosis. One is diffuse systemic sclerosis, and another one is limited systemic sclerosis. Whenever it is diffuse systemic sclerosis, the antibodies are diffuse. So there will be anti-SCL70 antibody that is 99% specific. When we talk about the limited systemic sclerosis, it is limited. So the antibodies are limited to certain part of the chromosome structure. That is how I remembered it is anti-centromere antibody, which is 97% specific. I also want you to understand that an elderly patient presenting with weight loss, now presenting with muscle pain, increased CK, has got Cotran's papules. The diagnosis is dermatomyositis, and anti-Jo1 antibodies are 99% specific for dermatomyositis, please. Polymyositis patient will be a middle-aged female patient or a male patient associated with pain and increased CK. That is when you'll have to think of polymyositis. That's the most important question you will be asked. If you want to score 265, you will have to differentiate between polymyositis and inclusion body myositis. Very important. Remember, inclusion body myositis usually involves the proximal part and is affecting the middle-aged female. That is inclusion body myositis. Polymyositis is usually an average elderly. All right. Next, we talk about adult still disease. Adult still disease, I remember it as patient, any patient presenting with the recurrent fevers. Remember, patient will be having fever better when taking paracetamol, and patient will be normal for a day, and then the patient will have recurrent fever with the rash and has got joint pains. Think of dengue, think of chikungunya, think of adult Still's disease. Very important. These three differential diagnoses I want you to remember. But what is the difference between adult Still's disease and dengue and chikungunya? Adult Still's disease is basically an inflammatory disorder. So there will be arthritis and there will also be arthralgia. The patient will be having recurrent high fevers, and patient will have a rash, which is a maculopapular rash or a salmon colored rash. Remember, dengue fever will present with fever and also thrombocytopenia. That's the most important thing you'll have to remember. However, there will be arthralgia, but there is no arthritis. Please remember this. Chikungunya, there will be fever and severe joint pains are the characteristic thing. In chikungunya, you will not find thrombocytopenia. Very important. Next, we talk about systemic sclerosis and scleroderma renal crisis. I put these together because you'll have to differentiate what the examiner is asking you. Remember, examiner is not interested in systemic sclerosis because every medical student knows about systemic sclerosis. It is the complications that the examiner wants you to know. The complications for systemic sclerosis is it involves the lung, it involves the kidney, it involves the heart as far as USMLE step 2 is concerned.
Please, we can hear you. It's breaking.